Hello and welcome to this podcast from the BBC World Service. Please let us know what you think and tell other people about us on social media. Podcasts from the BBC World Service are supported by advertising.
This is the sound of crowd science.
We shoot a laser beam at this atom.
Is that a big canister of oxygen in the background?
Oh, there's a wasp in there.
Yep.
That's possibly the most disgusting thing I've heard this week.
But it's one of the nicest fun facts you're going to hear today.
So here I'm actually holding a donut.
What are you going to do with that?
Find out more at the end of this podcast.
Hello and a very warm welcome to The Evidence from the BBC. I'm Claudia Hammond and this series is produced in collaboration with Wellcome Collection, and we're back in their reading room in London in front of a live audience. And today we are returning to the subject of COVID-19. For the first 2 years of the pandemic, it was the topic we looked at in every episode of The Evidence. And in Health Check on the BBC World Service, we've carried on covering new findings, of course. But it tells us something that on The Evidence, it's been a while since we've looked at COVID. And at times, it can feel as though it's all gone away. Now, I can hardly believe that this is the third year of this global health crisis. And I catch myself, and I'm sure you do too, becoming numb to the numbers. 6.5 million dead, more than 100 times that number recorded to have been infected, and probably way above that. And if it wasn't for the incredible vaccine rollout, which of course many have yet to benefit from, the death toll would have been much, much higher. And we do so want it all to be over. And in fact, a couple of weeks ago, President Biden said that it was. So today we're going to put the emotion and the wishful thinking to one side, and we're going to look at the facts, the evidence. When is a pandemic actually over, and how do we know? And I'm joined today by a really illustrious panel. We have the global leaders in their field who have played key roles in the response to COVID-19, and all of them have joined me on The Evidence before. So I'm delighted to have here from Geneva, we have Dr. Maria van Kerkhove, who leads the WHO's work on emerging diseases, and she is an infectious disease epidemiologist. It's a real pleasure to have you on the programme in person, Maria. Thank you so much for coming. And Sir Jeremy Farrar hasn't had to come far from his office because he's based here as Director of Wellcome. And Jeremy is an infectious diseases specialist, and he advised the UK government on their COVID response. And the audience here can see our next guest on the screen, but those of you listening elsewhere should also be able to hear him perfectly. Welcome back to The Evidence, Professor Salim Abdool Karim. Now, Salim is co-chair of the South African Ministerial Advisory Committee on COVID-19, and he sits on the Africa Task Force, overseeing the African continent's response to the virus. Now, he's a clinical infectious diseases epidemiologist, and he's talking to us not from South Africa, but from across the Irish Sea in Belfast, in Northern Ireland, where he's addressing a conference. So near and yet so far, Salim, but lovely to have you back on the programme. And I want to start with you, if I can, Salim. What is your reaction to declarations from some quarters that the pandemic is over?
I think we all have a sense of being tired of this virus, being fed up, and we would want it to be over. But unfortunately, the only organization can really call it to be over is the one that called it in the first place, and that's the World Health Organization. I think it's very unwise if we have unilateral declarations of the pandemic being over in individual countries by political leaders. I think this is a much more complex issue that needs very careful scientific assessment.
And Maria, the Director General of the WHO, has said recently that the end may be in sight. I mean, I guess he wasn't saying we're there yet, it's already over.
No, he didn't say that the end is here. He said that the end is in sight. And really what it is a hopeful message. We're not out of the woods yet. It's a global problem requiring global solutions, and the emergency of COVID-19 may be over in some countries because they have been able to use these incredible tools that exist, vaccines that are saving lives, antivirals, diagnostic tests, personal protective equipment, but the access to those tools is not the same everywhere. And the impact of this virus is still killing between 10 and 15,000 people per week. In the last month alone, more than 51,000 people have died from COVID-19. These are deaths that can be prevented. So the emergency is not over. The pandemic is not over, But we're hopeful. We can see that end in sight. We can see what living with COVID will be responsibly. We're just not there yet.
So I wonder if, in a way, it's just a question of definitions, and that maybe President Biden might not have been using, the strict epidemiological definition, if you like, of what a pandemic is, but a sense that for many, life is back to normal or feels a bit like normal.
Well, it isn't just a matter of definitions. Pandemic is something that covers the entire globe. As the World Health Organization, the Director General declares a public health emergency of international concern. We actually don't declare the start of a pandemic or even the end of a pandemic. It's very difficult. This virus will be with us, and so we will be dealing with this for many, many years. Doesn't mean we have to deal with it at the level that we're in. But we will declare, the Director General will declare this public health emergency of international concern, over when it's not an emergency everywhere. And our emergency committee, which was established by the international health regulations, is discussing what the criteria need to be to say we're out of the woods of the emergency at a global level. We don't declare pandemics because what we want to declare is an emergency to prevent us from getting to that in the first place. The public health emergency of international concern was declared on January 30th, 2020. When it was described or characterized as a pandemic, we were in a pandemic. The whole point of the alarm system is so you prevent the pandemic from happening. We weren't able to do that for a variety of reasons, but we characterized it, described it as a pandemic. And I do understand that it's kind of complicated in terms of people's understanding of that, but we will get out of this. That's the point.
And Jeremy, isn't the difficulty that the trouble is we do just desperately want it to be over, don't we? And there are loads of other things to worry about going on in the world as well at the moment. What would you say to leaders who are tempted to say, well, this is mission accomplished?
I think the last US president that declared mission accomplished probably wish he hadn't said it when he said it either. And unfortunately, I think it's got to appreciate that just because you will something to happen or you want something to happen or you desperately hope something, it's not quite the same as something happening. And just to reiterate what Slim and Maria said there, I mean, the pandemic, firstly, this infection is with humanity forever. I don't believe the infection is going to disappear from humanity, is personal view. In the streets of London today, about 1 in 60 people are infected.
That's quite a lot, really, isn't it?
That's an extraordinary high rate, and that is at the low point of this wave of the COVID pandemic. And we don't yet know the long-term consequences of infection and repeated infections. And I think we've got to use the tools we've got. We've got to make sure that those tools are available in an equitable way to everybody that uses them. And we would be wise to not call the end of a pandemic just because we hope it's coming to an end.
Well, I want to talk some more about this in a moment, but before that, let's see what history can teach us about when pandemics are over. And we're lucky to have here at Wellcome an incredibly rich archive of medical history and the person to help us mine it, who is Ross McFarlane, who is Research Development Lead here. Welcome back to the programme, Ross.
Great. Thanks so much, Claudia.
Can we go back 100 years or more to the flu pandemic of 1918 and the years following? And, of course, that had waves as well, didn't it, in the same way that this pandemic has had waves. Can you remind us about the scale of that earlier pandemic?
Yeah, so just in a sense of scale and infection, the statistics seem to suggest about 500 million people were infected with influenza in 1918, 1919. The death toll was in the realms of 50 million people. Even that number is an estimate from recent research. So it is a huge worldwide issue. And certainly with regard to the idea of waves, and we thought about waves of COVID, the waves of influenza in 1918, 1919, it pretty much dates from March to August 1918 as the first wave, September 1918 to December 1918, which was the most deadly of the waves, the second wave, and the last wave from January to May 1919. So again, the sense of a pandemic rolling around, in the sense of waves travelling around the world at that time.
And how much information was there around at the time about what exactly this was?
One of the issues with regard to how information could be spread out and shared was that there was no overall authority, some global surveillance in the way that exists now with the WHO. So it was very much in ways designed for each country by themselves to work out what to do and pass information on as they saw fit. But one of the dangers at the time was how that information was shared. So, for example, in Britain, the sense was to be feared of fear, to be frightened of fear. The sense that if people panicked, that would spread the influenza around a lot more. And one of the problems was with that information, Britain as a head of its empire, the Colonial Office, even though it knew about the first wave, did not pass on information to the dependent countries as part of the empire. So what I've got with me to give you a sense of pandemics coming to an end, in inverted commas, is I've got a volume of the Journal of the American Medical Association from our collections here. This is a letter from a medic in London writing to the editors of the journal in the United States. And it's going from August 20th, and it says, "The influenza epidemic described in recent letters has completely disappeared." So that is the first wave. The second wave is about to arrive. So it's that sense of what records can give to us, the sense of being in the moment and not knowing what the future holds.
And were there voices of caution as well, saying, well, it's not over yet?
Yeah, so in Britain, the responsibilities for looking after local populations was designated down to local authorities. And one particular medical officer of health for Manchester, a chap called James Niven, he actually warned after the first wave, start wearing masks, start closing schools. And he was one of the most prominent of these local officials to try and suggest there was ways to counteract this. And certainly with regards to the dependent countries through the Colonial Office, they shared information amongst themselves. For example, at Sierra Leone, the authorities there told Ghana, told Gambia about what was going on. So word spread in that direction without the advice from the Colonial Office. And they worked very hard at the time to try and stem the flow of influenza.
And so was it ever announced formally, this is now over?
That's a really good question, because there was not that sort of international surveillance with the WHO. It's almost a case of country by country announces that. And one way of sort of marking that sense is the official reports into the pandemic and how there might be a biological end, the case numbers might decrease, but where a social end happens towards the end of a pandemic can be something very different indeed.
Well, thank you very much for that, Ross. And so coming back to what might happen today, Salim, we were talking earlier about whether the WHO might declare that it's no longer an emergency and that they're meeting every so often to discuss this. It's not just about words, is it? What are the implications if they do say it's not an emergency anymore? What then happens?
I think the principal issue is one of perception and understanding risk, because our ability and willingness to adopt risk-reducing measures like wearing masks and keeping a distance and so on, they are dependent on individuals acknowledging their own risk. And if we say that the pandemic is over, then we basically are saying to people, you're no longer at risk. And if you're no longer at risk, you don't have to take these measures. It also creates a situation where we undermine public confidence in the authorities. If they prematurely declare something is over and then we go through a new wave of infections, what does it say about our leadership that they can't even get this right? So we have to be very careful, because many of the things we do in managing pandemics and epidemics need the public to trust and have confidence in the authorities. Otherwise, they won't be part and parcel, they won't buy into the interventions that are needed.
And Jeremy, I wonder if you could have the opposite as well. If it continues being called an emergency for a long time and you continue saying this is very, very serious, and then you don't see big peaks, will people then say, oh, well, you know, you said it's an emergency, but it's not anymore?
Yeah, that's the balance to be struck. But communicating the uncertainty, communicating what we know and what we don't know, and building trust, I would argue, before a crisis hits, is what you depend on when a crisis subsequently hits. It was great to hear that history, and very strong reminder as well. That was 100 years ago. I would bet my bottom pound or dollar, they're about the same now, that there'll be people sitting in this room 100 years from now debating the COVID pandemic. When you look back in 1918 and you hear those stories, it almost feels a little bit romantic, those stories. The truth is, living through history is really hard. It's painful, it's frightening, it's chaotic. is really difficult to do.
Yes, and Maria, amongst that chaos, I suppose there are practical consequences as well, aren't there? So if an end to the emergency is called, it's not just about words, is it? Other things come into play from that, or stop coming into play.
It does, and I think this idea, this notion of this start and stop is part of the problem. What we're trying to do is we're trying to build pandemic preparedness, readiness, response as a constant. This emergency is not over. I am really sorry to say this, but I think we need to be absolutely clear. There will be further waves of infection. The 1918 pandemic, the virus, that influenza virus, has circulated for decades. The severe disease, the death, that devastation ended, but the virus stayed. This virus, this SARS-CoV-2 virus, is here with us to stay, but it does, so future waves of infection do not need to mean future waves of death, and we have a role to play in that. So what we need is right-sizing the response. We need to calibrate the response going forward. We've just recently issued these policy briefs, which is saying, listen, we get this. 3 years into the pandemic, you're tired of talking about this. You're tired of hearing about this. I'm tired of talking about this. I would love to never have to talk about this again, but we have a responsibility to keep people and governments ready. And so we need to calibrate the response. How do you deal with COVID in light of everything else? Every other health crisis and non-health crisis, energy crisis, flooding, droughts, war, displacement, and all of the diseases that were put on the back burner that haven't been dealt with over the last couple of years. This is what scares me the most, complacency. We're tired of this. We don't want to talk about these numbers anymore. We're numb to them. We can't be numb to them. We have to keep fighting. And I'm sorry to use a war analogy, but we have to keep fighting, and we can. So I'm optimistic because I know we can do this. We just have to kind of keep pushing to end this pandemic, end this emergency everywhere.
And Salim, this issue of how to deal with this compared with other diseases, which were neglected for a time, particularly in sub-Saharan Africa during the pandemic, is a really tricky one, isn't it? Because you have got a lot of other diseases to worry about as well, and in other parts of the world too.
So we, in Africa, see something in the region of 8 to 10 different kinds of epidemics. Many of them are small, localized epidemics, but that's just part and parcel of life because we cohabitate this world with viruses and bacteria, and we've got to learn to live with them. Because this virus can infect animals, it can infect dogs and cats and so on, it's going to be with us for many, many years. But what we are getting to at this stage is the end of the first part. I'll just use a broad word of pandemic emergency. This point where people were really concerned and they had to change their lives and couldn't go to work. We're reaching the tail end of the pandemic emergency. We're not over the pandemic emergency because we are likely to see new waves of infection, new variants that can escape immunity. And so we're not yet over the pandemic emergency. But if we can get through that, then we will go through a different kind of period with this virus where it'll circulate, it'll cause small waves of infections, but it won't cause the devastation that we have seen in the first 2 years of this pandemic.
And Jeremy, there has been amazing global collaboration when it comes to tracking the virus and tracking the changes. And of course, South African scientists shared the details about Omicron with the world, and then we saw what was happening there. Is that information still available? Is everywhere still tracking it and sequencing the virus to find out what's happening?
Yeah, it has been remarkable, and you're absolutely right to pull out Salim and other colleagues that he will be the first to acknowledge in South Africa that alerted the world. So whilst there has been tremendous global cooperation, you're right, we mustn't stop that. And actually I feel at the moment that with the geopolitical situation we're in, that actually we are at one of our most vulnerable points in my professional career, because a lot of that collaboration and cooperation has actually stopped. And there is less sharing of information between certain countries at the moment as geopolitical tensions move out. And what we need to do, in my view, for this is to make sure that WHO is at the centre of it as the global public health body that didn't exist in 1918, and that they are allowed to put politics aside and focus on the technical cooperation that needs to go on to make sure people are sharing what can be can be shared.
Maria, how much is getting shared now? I mean, there is much less testing in most places going on, isn't there? So
Yeah,
then you haven't got it to sequence.
That's right. There's a big shift in testing policies around the world, and the numbers of tests have dropped precipitously over the last several months. And you can't sequence who you don't test. So sequencing has dropped about 90% since January 2022, when Omicron was first identified and first reported by researchers in South Africa. And that limits our ability to assess and track the known variants. And there are more than 200 subvariants of Omicron that we're currently tracking right now.
200? 200 right now?
200. 200 sublineages of Omicron need to be tracked. So we've gone from several 100,000 sequences available on a weekly basis to 90% less, 10,000 per week. And that limits our ability. I've never been less confident, I have to say, right now, during this entire pandemic, of our ability to assess known variants and identify new ones. Omicron, variants of concern, the dominant sublineage of Omicron right now is BA.5, but we're really concerned about BA.2.75.2. It gets very confusing with these numbers. They get longer and longer, but they're all Omicron and they all have similar characteristics. What our concern is transmission. The next variant of concern will be more transmissible because it has to outcompete whatever's circulating. We don't know if there will be further immune escape, meaning that our body's immune response is not as strong or as robust as it could be going forward. But we don't know if these further variants will be more or less severe. And we have to be ready. So we need the systems that are in place. We need a stronger global health architecture, a stronger surveillance to be able to surge up and surge down. Without surveillance, without sequencing, we're compromised.
So it sounds as though, so that the rest of us can not worry about it all the time, what we do need is scientists worrying about it for us in the background to try to work out what's going on.
That's right.
Now, before we break for the news, I'd like to pin each of you down with when you think the pandemic emergency will be over. Jeremy, what do you think?
I'm glad you're going first.
It doesn't necessarily make it easier being last.
Not in the next 6 months.
Oh, okay. Salim, what do you think?
I think we are likely to see a few more waves of new variants, and I think we're probably looking at within the next 2-3 years or so that the virus will get to a point where it can't really continue to mutate to such big advantages so that it can escape immunity to the same extent.
Maria, what would you say?
We had said in our latest global strategy that we wanted to end the emergency this year. I don't necessarily think we're going to be able to reach that target by December 2022, but we could by December 2023. Maybe you can have us back in the springtime, and we can you can ask us that again. But one of the things is we just have to remain humble. We have to remain humble to the uncertainty as we go forward, and we need countries to be able to surge up, surge down, and deal with that uncertainty. That's really the goal that we want.
Well, we will see what happens. Thank you very much for the moment. We are breaking for the BBC News now, and thanks to Ross McFarlane for sharing that incredible archive with us earlier. I'll be back with Maria van Kerkhove, Jeremy Farrar and Salim Abdool Karim after the news, when we'll also be exploring what life might be like living alongside this virus. I'm Claudia Hammond, and I'll be back soon with the evidence from the BBC. Hello, I'm Claudia Hammond. Welcome back to The Evidence and to Wellcome Collection in London, where I'm with a live audience and we're talking about COVID-19 and what it means for all of us to live alongside this virus, if that's what we have to do, and what we can learn from the mistakes and successes that we've seen so far. And I have an eminent panel of scientists who've played key roles in managing this global health crisis. Dr. Maria van Kerkhove is the WHO's technical lead for COVID-19 and has been a familiar face throughout this pandemic as she has explained calmly, time and time again, the new evidence as it has emerged. Professor Salim Abdool Karim is co-chair of the South African Ministerial Advisory Committee on COVID-19, and he's a regular guest on this show and somebody with a central role in the response to the virus across the African continent. And Sir Jeremy Farrar is Director of Wellcome and a powerful voice for global cooperation. Salim, if we can look now at where we are with case rates, South Africa, for example, if you look at the graph, it's worth looking up because it's so neat. There are these neat 6-monthly peaks of infection. What are you expecting in the next few months? Does that mean you might be looking in, say, November to see if you get another peak?
Yes, it's been quite striking that when you analyze the waves of infection in South Africa, there's a level of periodicity in the rate at which they come, that the gap, the interwave period between each of our 5 waves varies between 94 and 99 days. So it's actually not too difficult to just add 94 to 99 days to have some idea about when the next wave is going to come. And I remember when I was asked in September last year, when's the next wave? And I said, we don't know. And when pressed, I eventually said, okay, it's the 2nd of December based on a quick calculation. And what happened was exactly on the 2nd of December, South Africa passed the threshold for the Omicron wave. So we are learning a lot more, and we are in a different situation today than we were in 2020. We have a better understanding about the behavior of this virus, and it's enabling us to have a better sense about when we're likely to see waves, because that's going to be critical to getting back to normal, so that we know when it's risky and when it's not risky, and we can adjust our appetite for that risk and ensure that we are increasing the use of our public health measures when we think the risk is high, but not worrying about doing that when the risk is low. So South Africa right now is just about going into its 6th wave, and the cases are going up. Unfortunately, it's largely being hidden because we're not doing enough testing. And that's my big worry, that this next wave is likely to be a significant wave if there's a new variant. But we will miss the new variant because we have so few sequences now, because we're just not doing enough testing. So Maria, highlighted this very significant problem that you won't find what you don't look for. So we've got to get people to test. So that is very much what's going to influence when and how the next waves occur in South Africa.
Yeah, and it sounds as though this next wave is going to be a very interesting one to look at to see what does happen. And Jeremy, in the UK, there's been a very slight rise in numbers of cases in the last couple of weeks, and people are discussing whether there will be a big peak this winter. But of course, when we look at the South African experience, the peaks there aren't necessarily always in winter, because they're every 6 months. Is there a risk that we assume winter's always the time to worry about, and maybe it isn't? I mean, the last big peak here was in July.
Yeah, I think the fact that, as Slim's just said, the numbers in South Africa are going up at the moment. South Africa is about, as far as I'm aware, Slim, about to go into spring and summer. In the Northern Hemisphere, we're about to go into our autumn and winter. And yet in the UK at the moment, as I said, in the streets of London, it's about 1 in 60 people infected. And the numbers are going up. So we're back onto a wave. Just one thing I'd pick up on both what Miriam and Slim said is, I think the scenario that we've all been painting is the most likely scenario. But it is not the only scenario. And whilst I absolutely accept that political messaging and public messaging, etc., should be based on policy making about the most likely scenario, it's absolutely critical that at least some of us, are working on the other scenarios, because the public does not deserve to go back to March of 2020. And if there was a variant, even if the risk was 1%, let's say, over the next 2 years, that escaped the vaccines, and we hadn't considered that and closed that off as a possibility by having next-generation vaccines, transmission-blocking vaccines, vaccines against other variants, preparation for another epidemic, I don't think the public would ever forgive us. So I'm fully in favour of the most likely scenario being painted, but some of us have got to work behind the scenes to make sure we're prepared for some of the other scenarios that may pan out.
And of course, Maria, we've talked a bit about vaccines, but vaccines are going to be absolutely crucial in this. Is there a risk now that people will think, oh, Omicron seems to have been milder, so we don't need to worry so much anymore? Or do you think people who can get vaccines, which of course is not everybody, will be keen to, and that will be the key?
So there are next generation vaccines that are in development. There are a lot of groups that are looking at the composition of those vaccines and whether or not they should contain subvariants of Omicron, and several of them do. The message that we have out there is when a vaccine is offered to you, if a booster is recommended for you, get that booster, get that vaccine.
So you don't wait around thinking, oh, but I want the one that's got a bit of this and a bit of that.
No, we're not asking people to wait. We're saying get the vaccine because immunity wanes over time. And we don't know enough about how long immunity lasts. Many people around the world have been vaccinated. They've had multiple vaccines. They've also been infected. I'm one of those individuals. I'm sure many of you are as well. But we should expect to be infected going forward. It doesn't need to translate into something severe. It doesn't, future waves of infection do not need to translate into increased waves of hospitalization. We would really like to see a shift in surveillance in countries to measure burden. What are the hospitalization rates in countries? What is the percentage of people who are requiring intensive care? How many require to be on oxygen or ventilation? How many of those are vaccinated? What is the age profile of those? So that we can better understand the impact going forward. We're not in a good situation globally to be able to assess this. But the message is get vaccinated when it's your turn. Get those boosters when it is recommended for you. And we need further investment in the next generation of vaccines. We need vaccines that not only focus on severe disease and preventing severe disease and death, we need to also look at those that will block transmission. We haven't mentioned at all long COVID. And this is something that we have to plan for. Post-COVID-19 condition, or sometimes called long COVID, is something that hundreds of millions of people right now are dealing with. We don't actually know how many people are dealing with this at the moment. There was an estimate of about 144 million people dealing with post-COVID-19 condition before Omicron circulated. And these are long-term effects that affect the heart, that affect the lungs, affect the brain, and really are quite debilitating. And we don't have enough research in this area. We need funding for research for this as well. So again, hopeful that we can deal with this and live with this virus responsibly, but we're just not out of the woods yet.
Salim, what is the situation when it comes to availability of vaccines in sub-Saharan Africa? Is anything improving on that front?
Most of Africa went through a pretty awful period where we just couldn't get vaccines. And now that that issue has been addressed and supply is no longer a challenge on the continent, we have a different problem. And that problem relates to willingness to take a vaccine. And part of that challenge, again, relates to perception of risk. So you take a vaccine or you want to go and get a vaccine if you perceive yourself to be at risk. But because the vaccines got to us so late, when we were now dealing with a variant that was much less threatening, and the perception that was that, this is not as serious a problem, we have a situation where the perception of risk is much lower. And in a context where the health service capability to deliver this in a way that will make it easy for people to get vaccinated, isn't readily there. Because remember, in Africa and pretty much most of the world, we don't really give vaccines. We don't have a program for vaccines for adults. Our vaccines have traditionally been for children. And those systems are inappropriate and they're not designed for adults. And so we're having to develop new systems. And in fragile healthcare services and health systems that are not well-resourced, that tends to be a challenge. I'm optimistic that we are moving into a situation where large parts of Africa have some combination of either multiple natural infections or multiple vaccinations or hybrid immunity, where in South Africa, for example, we've got probably in the region now of just over half our population has a hybrid immunity, which is a much better form of immunity in that it's a combination of natural infection plus vaccination, and it gives you very high levels of antibodies, more than if you had natural infection only or vaccination only. So we are in a better position, but we still have in the region of around 40 to 50% who haven't received a single dose of vaccine, and they are dependent on having had past infection to protect them from hospitalization in the future.
And Jeremy, there is this ideal of having a universal vaccine so that whatever variants might come along, that one single vaccine will work for that. How far off is that? Are there many groups working on that?
There's a lot of groups working on it, and most scientists will always tell you it's about 5 years away. Everything's always 5 years away. HIV was 5 years away for a vaccine when I started a medical career, as Slim will remember. I think the scientific progress of the last 2 or 3 years has been staggering. But remember, it has been on the basis of many, many years, decades actually, of investment in basic science. Everyone says the vaccines came along in a year. They didn't. They came along because of many years of investment from many people all around the world in basic science. And governments must be reminded of this. It's very easy to sort of describe these as sexy things which come along when you want them. They come off years of basic science, and we should continue to make sure we invest in that. We will, I believe, get to a vaccine which blocks transmission, which acts beyond just this type of virus, but other coronaviruses. That should be our goal, and we should aim, I think, to get there this decade, so that we can put this family of viruses, the coronavirus family of viruses, that could not cause this sort of pandemic again. And then we should think what viruses are out there in the animal kingdom, mostly, and we should say, let's commit ourselves to making sure humanity has putative or potential vaccines for all of those, so we never go through a pandemic like this again. So
there's a lot of work to be done there. And Maria, if we do get these universal vaccines, which would be amazing, of course, that's only going to be any good if everyone can get hold of them. Did you ever think that 3 years into the pandemic, you'd still be urging equity around vaccinations for all? I mean, what does it feel like that you're still having to do that in a way?
I just have some statistics on the vaccines. To date, more than 12.6 billion doses of vaccine have been administered globally. And 75% of our health workers and older populations have been vaccinated. But 25% of the world's older people and health workers have not been vaccinated. 32% of the world has not received a single dose of vaccine. We're not done. We're not done yet. So we don't have to be the sky is falling, this crisis running around. We need a calm, focused attention to find those who are most at risk, vaccinate those who are most at risk, because this is saving lives. Vaccine equity is not a hashtag, it's not a slogan, it's not something that those of us at WHO and our partners, many of our partners, are working on this through COVAX and through other mechanisms to achieve, because health is a fundamental human right. Access to all of these types of tools that save lives is a fundamental right that we have, and it's something we really have to continue to work on. We haven't reached it yet, even in this pandemic. Out of the 12 billion vaccines that have been used, and out of the donations and promises that high-income countries have made, those vaccines have not actually reached the countries yet. And a lot of doses are being thrown away because they're expiring. And so, as Salim pointed out, we don't have vaccine programs for adults in all countries. This is something that has to be worked on. There's efforts underway of tech transfer so that other production sites can actually make the vaccines, to have more actual production facilities around the world so that it's not just high-income countries that can produce the vaccines, but others can have ownership and take ownership of that. So there's a lot of work underway, and this has been nice to see over the last couple of years, but we have a long ways to go. We're definitely not in the place where we need to be. And knowing that we will need further vaccines going forward, knowing that we will need further boosters going forward, this is something that we still have to address today.
I just want to ask each of you briefly about what has gone wrong with the response so far and what lessons we can learn from that. Salim, you were the co-author of the recent Lancet Commission on the lessons for the future from the COVID-19 pandemic. So you are the perfect person for this. And the failure to share vaccines equitably was just one of the conclusions you reached in this report. But you also named excessive nationalism as a core failing. How do you differentiate between nationalism, which is presumably a country doing its best for its citizens, and excessive nationalism in the context of a global pandemic?
So one of the things that's probably the most certain in this pandemic is that it's uncertain. We don't know so much about what we're dealing with. But we can take the lessons that we've learned from COVID-19 and take them forward as we think and plan and prepare for the next pandemic. And those lessons are critically important. One of the things that we challenged very early on was this notion that wealthy countries could have ready access to the first doses of vaccines, and that the poorer countries would have to stand at the back of the queue. And that global inequity became intolerable in many ways. And in the midst of all of that, a group of us, led by Jeff Lazarus from Barcelona, decided to try and measure wastage. Mm-hmm. And wastage occurs in different ways in vaccines. So at a time when vaccines were not available widely in Africa, there were wastage in the millions of doses in several countries because they hoarded it. They hoarded it instead, and they were trying to give it away just before expiry. So it actually compounds the problem when you do that, because a country has to drop everything else to try and vaccinate. So it compromises measles vaccination, HIV and TB care, because you're pushing the healthcare system to act in those kinds of ways. So I think what we will need to appreciate is that we've got to take that lesson and make sure that when the next coronavirus comes or influenza comes, that we never go down this road again, and that vaccines and the essential elements like diagnostics and so on are available to the global community in a much more equitable way.
And here's a trickier question for you, Salim, but an important one, I think, is there anything now, looking back, that you wish personally you'd done differently in all this?
One of the challenges that we had in South Africa was that we took a decision early on not to try and make a vaccine because our vaccine capability had been decimated. Now, just to give context to that, prior to 1990, South Africa was completely independent in terms of vaccines. We made all our own vaccines. We made our own polio vaccines, DPT vaccines, all our own vaccines. So we could make vaccines. But because the world has progressively changed and the regulatory environment and the cost environment landed up with a situation where it's cheaper to buy the vaccines from India or elsewhere, we scaled back that capacity. And that scaling back meant that we didn't have the ability to make vaccines. And I think that for me, and I've publicly stated this, that I should have been much more vociferous in getting South Africa to put the energy into making vaccines. And of course, now the WHO has stepped in and many other governments have stepped in to help Africa, creating the mRNA technology hub and many things to fix that wrong. And that's the one thing I've always regretted, that I didn't put more energy into vaccine development in Africa.
And Jeremy, I wonder, is there anything where you kick yourself and think, I could have done that differently, or persuaded someone to do this? Or...
Yeah, most days through 2020. Can I just answer the one that you asked, Slim, as well? Just on one strong feeling I have is that we must stop seeing these things happening as A, shocks, and B, as discrete episodes. We three have all been involved, from Slim in HIV, Maria and myself in SARS-1 and MERS and many others. The world is changing around us, and these things, COVID, MERS, whatever you want to call them, they're the symptoms of a changing world. Mm-hmm. And the changing world is about land use change, environment change, climate change, urbanization, trade and travel. And if we only address the symptoms and we don't ultimately address the underlying drivers of what's driving these epidemics, mostly from the animal sector coming into humans, we will face more complex and more frequent epidemics in the future.
They'll be harder. Issues, though, aren't they? They're huge issues to try to deal with all those things.
They are, but that's the 21st century. You know, the century we're living in is this century, not the last one. And if we don't address those drivers and bring together these issues of fragmentation and disparate sort of ways, we will face more frequent and more complex, as we have done in the last 20 years. Ebola in West Africa in 2014, which we were both very involved in, the virus hadn't changed. The people hadn't changed. What had changed was the environment in which it was happening in. It was transmission in big cities and at cross-border places. That's what drove the dreadful Ebola outbreak in West Africa in 2014 to 2016. So unless we address those drivers, we will see more frequent and more complex epidemics in the future.
And what would you do differently if you could go back?
I would have pushed harder. I felt as if I pushed as hard as I could, but I would have pushed harder in the United Kingdom to use the summer of 2020 to prepare for the inevitable waves of the winter of 2020, and I think that would have saved an enormous number of lives if some political decisions had been made differently in September, October and November of 2020.
And Maria, how was it in a way that the world wasn't prepared for this when people said again and again this kind of thing was going to happen? What could have been done differently?
Oh, I mean, how long is the program here?
Briefly, please.
Briefly. It is the underlying cause. What we saw in the beginning of this pandemic is countries that really fared well in the beginning had a previous trauma. Really had gone through something similar. They had gone through Ebola, they had gone through SARS, they had gone through outbreaks of avian influenza, they had gone through MERS outbreaks, that had caused billions of dollars worth of damage to their economies, and killed individuals, and they made changes based on that trauma. They changed their infrastructure of a workforce. They built a workforce, community-based workforce. They had systems that linked data together electronically. They changed public health law. That trauma led to some change. Every single country on the planet has gone through COVID-19, is still going through this, and has gone through a trauma. We're not seeing the changes that are necessary to be in a better place going forward. This is what scares me. We are not prepared. We were not prepared for COVID-19, and quite frankly, we are not as well prepared as we need to be for the next one. So we need governments to, a lot of the time in the summer, everybody wants a break. Give me a break. I don't want to talk about this anymore. But governments have to be ready and be vigilant and get those systems in place and build that foundation to be stronger. We're trying to change the global health architecture going forward. We're trying to make sure that we have financing that doesn't just deal with a response, but deals with preparedness and readiness and gets to some of these underlying causes. My day job is on dealing with emerging diseases and zoonoses. What is the next one? What's the next one that's coming down the pipeline? Will it be respiratory? Certainly. Will it be influenza? Probably. We can be better prepared for that. Could it be an arbovirus that's spread by a mosquito? Possibly. We had Zika. Everyone forgets about that in the past. Could it be a rodent-borne virus? There's a lot of what ifs. There's a lot of scenarios that the World Health Organization is looking at, but we need political will. You can have the best plan in place, but if you don't have strong political leadership, if you don't have the financing to back it up, that plan is useless. So there's a lot that we've really learned in this pandemic. We just have to continue to make those changes and continue to push, continue to fight to ensure that we have a stronger foundation.
And knowing what you know now, is there anything that you wish you'd done differently personally?
Oh, so much. I think about this quite a lot, in fact, but I don't think it's necessarily fair to say what I know now, what I would have changed. What I try to do and what we try to do as a team within the World Health Organization, we're a learning organization. We are perfectly imperfect, as is every organization on the planet. But what would I have done differently in terms of the role that I had, knowing that the uncertainty that unfolds, there's quite a lot. I think that we've expanded our partnerships and technical reach around the world because everybody went virtually. That's been quite a positive. I don't know. It's a difficult question. I think communicating the uncertainty, this role that I've had, this forward-facing role, was not part of the plan. This is not my day job. I don't have training in this at all. But I think if we had, in some of the early decisions, when some of those decisions were changed, masks, for example, if we could have articulated, look, in the beginning, we wanted everyone sick wearing a mask, we wanted our health workers wearing a mask. At the time, the supply around the world there was no supply. We had health workers wearing plastic bags. We had an entire supply chain that failed because masks were produced in countries, in China, in Wuhan, for that matter. We had countries hoarding available supply. But then when we were able to say, look, supply has changed and here's why we've changed our recommendations, I think we could have done a better job in that, but I think everybody could have. So I think communicating uncertainty is hard. And I think a lot of us have learned how to do that a little bit better as we go forward. But those are the types of things that I think I would have changed personally going through this. But we're perfectly imperfect.
Well, thanks very much for all of those comments and for your honesty there. That is all we have time for, but thanks so much to all of you. Dr. Maria van Kerkhove, Professor Sir Jeremy Farrar and Professor Salim Abdool Karim. This show is made in collaboration with Wellcome Collection. Thank you to the producer, Fiona Hill, and our studio engineers, Giles Aspen and Emma Hart. And thank you to our audience here. I'm Claudia Hammond, and to hear more on global health, do join me every week on the BBC World Service for Health Check. Bye for now.
And while you're lying very, very still, you'll have a machine around you going, and you are completely done with contributing to science.
Crowd Science is the podcast that takes your questions about life and the world around us and goes in search of the answers.
How do we navigate in space?
With a little help from scientists and other specialists.
It was quite a kind of accidental thing. I didn't set out to become an ancient poo expert.
Am I just a bag of fluids?
About 60 to 70% of you is liquid.
Basically, we're just giant water balloons.
Why did humans lose their body hair as part of evolution?
That is a fantastic question.
Warning, it will put you off being in enclosed spaces with other humans.
What? That's Crowd Science from the BBC World Service.
The perfect spot to swing by if you have an appetite for answers or a thirst for knowledge.
Delicious.
Just search for Crowd Science wherever you found this podcast.